Good evening. Thank you very much. It's my pleasure to be here. I'm actually very excited to tell you a little bit about, I've had a little bit of shift in the trajectory of my research to move from explanations of disparities to actually moving towards addressing disparities in partnership with communities. So I'd like to share a little bit about that with you this evening. Now, I first became very interested in understanding the relationship disparities within breast cancer because of this graph. So here you can see on the left, we have breast cancer incidence, and we have African American women in the blue, and we have non-Hispanic white women in the orange. And so you can see that although African American women have lower rates of disease of breast cancer, they actually have higher rates of death from breast cancer. Now, all else being equal, if Black and white women in this country were to have the same experience, we would expect that white women would also have higher rates of breast cancer death. But we know that Black and white women do not have the same experience in this country, and that partially can be attributed to structural racism. And some of this can be explained through segregation, and I'm going to talk a little bit about how that might manifest today. So this structural racism really is causing an inextricable tie between race and socioeconomic status, and lower socioeconomic status really highly correlated with detrimental exposures to physical and social environments, and that this has health consequences. So researchers, including myself, have really been trying to understand, conceptualize, and test mechanisms through which environments may actually be embodied to affect health. So how is it that what is going on around you is changing your physiology and predisposing you to disease? And a lot of this research has focused on understanding how environments shape behaviors related to obesity as well as to stress, and I've done some of that work as well. But layered on top of that is the fundamental cause theory, which posits that populations who are economically or socially disadvantaged are actually excluded from health-promoting resources, including information, technology, and health services. And in that, lack of access also shapes social norms and the capacity to address health issues. So, are these models holding up within our present-day Seattle? Meaning that here we are in this very progressive and affluent city, and we're in this moment about 50 years after the passage of the U.S. Fair Housing Act. And I'm going to show you a series of maps that shows that actually, no, we're not having equal exposure to environments across Seattle and King County. Here we can see that higher rates of poverty, as illustrated in the red, are concentrated within South Seattle and South King County, and that overlaps with educational attainment as well as lack of access to health insurance and therefore health services, including mammography. And mammography has really been identified as a public health strategy that actually prevents cancer death. So with respect to that intersection that I talked about with respect to race and SES in Seattle, is that occurring within our area? And the answer is yes. African American residents are more likely to be living in South Seattle and South King County, and therefore exposed to these detrimental environments. And that's no accident. I mean, we have a history of restrictive covenants in this city. Now, what to do about it? So we know that Washington State actually does have a program to provide free breast and cervical screening to women who are un or underinsured, as well as women who are meeting federal poverty thresholds. But we also need to address the social norms as well as the capacity to be able to access the screening services that are available. And in partnership with my partners, we've identified fear and distrust of the medical system due to historic injustices, such as Tuskegee, as well as Henrietta Lacks and the use of her biospecimens without permission. And also a cultural silence around health issues within the community as areas to address. And to be able to do that effectively, the model of community health advocates or community health workers has been posited as one way of being able to infuse communities who are disenfranchised with health information and help facilitate access to services. And the reason being is that many of these individuals are actually members of the disenfranchised communities that they are serving, and they can actually leverage their knowledge of social norms as well as their insider status to promote trust between communities and health systems, as well as facilitate dialogue and support to promote a culture of health. So we know what we can do, so let's do it. And I had the opportunity to partner with an African American faith community here in Seattle, and really working with them for them to tell me what to do. What are the identified needs of the community, and how do they think that they want to address it? And so I was able to work with them to identify an evidence-based intervention, which we adapted to fit their needs, so to be able to bring breast cancer awareness to the community. And so as a part of that, we were able to train 16 lay community advocates, including 7 breast cancer survivors, and they delivered a program that reached over 150 members of their community. And 103 of those members were women who consented to provide pre and post information to measure the effectiveness of this program. And what we found that we increased knowledge, which included breast cancer risk, signs and symptoms, and knowledge of the screening guidelines by over 20%. And the way that that was able to be done was that the lay health advocates were able to share the knowledge through their own personal experiences and their testimonies to weave this information in a way that helped dispel the fear around accessing services and going through the process of diagnosis and treatment for cancer. And we also found that among those women, that 30% were not currently adherent to breast cancer screening guidelines, which is actually 11% higher than Healthy People 2020 objectives. And among those women, we were able to increase the number who said they intended to access screening within the coming year. So this project has been near and dear to my heart and has really spawned additional projects working in collaboration with the Health Promotion Research Center to be able to assess community health advocates and what we call patient navigators across health systems across the nation. So currently we're in the process of surveying over 1,200 navigators in 66 states, tribes, and territories. And so we're helping to use this information to be able to understand what exactly advocacy looks like with respect to cancer screening, and then also to be able to advocate for resources for those individuals to continue and sustain that work. Thank you.